Hello, my name is Dr. John Swisher. I'm a sports medicine physician and I work for Iowa Specialty Hospitals and Clinics. I was asked to provide a lecture on concussions today, so I've entitled my lecture Concussions 101. So today I'm hoping the audience will acquire a familiarity to the statistics behind concussions, acquire an understanding of basic concussion management, appreciate the differences in the effect of concussions on certain populations, and then understand the role of the protective equipment in contact sport. We're going to do this by, again, quickly broaching some of the statistics out there. We'll touch on causation, management on the sideline, talk about those special populations, a protective equipment discussion, and end with some final thoughts to hopefully lock in some of those important concepts. We really can't go any further without discussing the definition of a concussion. So the most recent definition is a concussion is a complex pathophysiologic process affecting the brain. It's induced by traumatic biomechanical forces. Now this can happen through direct or indirect forces. We need to know that this is a functional disturbance, meaning that neuroimaging such as a CT or MRI should be normal. It's short-lived and the symptoms will resolve on their own accord. And a small percentage of athletes, about 20 to 30%, will have prolonged symptoms. The majority of athletes will get better within 7 to 10 days. Currently, the CDC estimates about 44 million children and adolescents participating in sports yearly, and 170 million adults yearly. They do estimate 1.6 to 3.8 million concussions per year. Now this is very much an underestimate. A common study cited is one done by McRae and his colleagues back in 2004 that showed that 47% of athletes admitted to a concussion when they had suffered one. Out of those that did not admit to a concussion, 66% didn't think their injury was serious enough to warrant admission. 41% didn't want to be held out of competition, and 36% didn't know they had a concussion. Now this is a busy slide, but it does talk about a lot of key concepts here. So things to understand with this slide is know that the rate of concussion goes up from practice to competition. It goes up with the higher division of sports. Examples would be going from high school to college. Football has the highest overall number of concussions. It also has the highest rate of concussions in male sports. In women, it's soccer. A key concept too from this slide is to take a look at sports such as basketball, and then if we also look at things like baseball and softball, and knowing soccer, women have higher rates of concussion than their male colleagues. So how does a concussion occur? So there's a lot of confusion that exists on the mechanical etiology of how the brain moves in response to a concussion. As we know, a concussion can occur when the brain moves in any anatomical plane. The most common plane in experimental studies is what we call the coronal plane. So I tell folks to envision what the head does during an uppercut in boxing. We know that the brain can suffer a concussion whether the athlete is wearing a helmet or not wearing a helmet. Studies done in 2007 identified with accelerometers in helmets of football players that athletes can suffer concussions at variable thresholds. We also know that they have a preponderance of suffering a concussion when they strike with the crown of the helmet, hence only needing to reinforce good form. The two types of forces that result in concussion would be a direct force where the head is directly struck, but then also the indirect contact where the body is struck, transmitting that force to the brain, resulting in concussive symptoms. Now here's a couple of graphs that are somewhat busy, and I'm going to briefly touch on them. We talked already about how a concussion is functional. So what does that mean? So when a concussion occurs, it actually stretches the axon of the neuron. This leads to a cascade events that leads to neurological dysfunction. Early on, the brain needs sugar, what we call glucose. The brain is able to keep up with that for about 4 to 6 hours, and that's based off of studies in mice and rats. After about 4 to 6 hours, due to cellular dysfunction at the mitochondrial level, the brain is no longer able to keep up with that demand. What we also see is the cerebral blood flow tends to go down about that time. So we've got this imbalance between supply and demand. The cerebral blood flow does go down for about 7 to 10 days, which does correlate with what it takes for typical resolution of athletes with concussions in about 7 to 10 days. Some basic concepts for sideline management. Always have an emergency action plan, and for contact sports, I would absolutely recommend that you have an ambulance on sideline, whether it be for a scrimmage and or game. Each school should really have a concussion management plan in place. If not, we do have ours, and we're always happy to provide a copy to give you guys at least a place to start. So early on, recognition, an important concept to understand is grading and severity. So it used to be a very common place to grade concussions. We actually have not been grading concussions since about 2001. The reason why is there's about 26 grading scales out there, and none of them correlated to a safe return to play. Many times I'll have parents ask me how severe a concussion was, or even coaching staff. Honestly, this is what we call a retrospective review. So if an athlete has a concussion that lasts 3 to 4 days, and their second concussion lasts 14 days, we know that second concussion was a worse injury than the first. So as a medical professional on the sideline, I'm looking at different domains. So I take a look at the common symptoms associated with concussion. I'm going to test their brain. I'm going to check their balance, and then do a complete neurological exam to make sure they have no what we call focal neurological deficit, or symptoms that would resemble a stroke. For schools that don't have the luxury of having a medical staff on the sideline, a common means of trying to determine if somebody has a concussion is using what's called a SCAT-5. There is a very thorough form available. If you don't have medical staff on the sideline who can do this, it is quite lengthy, and coaches absolutely want to get back to coaching. So there is a pocket version of it that's abbreviated. Just make sure you know what form you have. There's a form for athletes 5 to 12 and a form for athletes 13 and beyond. Once you identify that an athlete likely has a concussion, absolutely no return to play. Now, an athlete can stand on the sideline as long as their symptoms are stable and or improving. If the symptoms are worsening, if they develop symptoms that would resemble a stroke, or you're worried about a cervical spine fracture, those are individuals that do need to be boarded and collared and sent to the emergency room right away. When an athlete is allowed to stay on the sideline for observation, please make sure you have a responsible adult accompanying them and monitoring them throughout the game to make sure they don't deteriorate and need to go to the emergency room. When an athlete is sent home with their parents, I commonly will send a take-home discharge instruction. This sheet will tell parents what they can do, what they no longer need to do, and also indications to go to the emergency room. We do recommend your athletes see a provider who is specialized in sports medicine and concussions, usually within a couple of days after their injury. They're going to coordinate a safe and as expeditious as possible return to play, assisted by your athletic training staff, but also the physical therapy department. So one slide here on computer-based neuropsych testing. We need to understand that there are multiple out there. The one most commonly cited is impact testing, but there are others such as COG, SPORT, and ANAM. Computer-based neuropsych testing does have some statistical flaws. It is not perfect. It is a tool in our toolkit. It should never be a standalone in concussion management and return to play. The current, most recent guidelines recommend the history and physical exam as a gold standard. So looking at our female athletes, we know that they have higher rates of concussion when you have the same sex matched sports. We also know that they take longer to recover. There are lots of theories out there postulated on this. None of them have ever been proven. The majority of concussions that I see are actually in the pediatric population. We also know they take longer to recover in contrast to their adult colleagues. Again, lots of theories postulated, but none of them ever proven. So helmets, they reduce the injuries of skull fractures and brain bleeds. There's a lot of biased studies out there currently that suggest certain helmets may reduce the incidence of concussions, but again, no good quality studies on that to date. There are a lot of current trends out there where companies are suggesting that we add padding or other forms of equipment to helmets. Again, a lot of biased studies on that. Also know that in the helmet there is a sticker, and it does suggest that if you alter the helmet in any way, you may void the warranty. This could potentially open a school and or coaching staff up to litigation. Mouth guards, we know that they reduce the incidence of dental oral trauma. There is not good quality evidence that they actually reduce concussion rates. This is based off of a very old study, but also a very flawed study. So some final thoughts. Remember, concussion rates are high and they are absolutely underreported. The injury is functional. It's not anatomical, meaning the CTs and MRIs will be normal. Each athlete's threshold for concussion is different. When in doubt, sit them out. Don't take a chance. Women and pediatric athletes do take longer to recover, so don't get nervous initially. Helmets and mouth guards do not prevent concussions based off of the current level of evidence that we have. Helmets reduce the incidence of skull fractures and brain bleeds. Mouth guards reduce the incidence of dental oral trauma. I want to take this time to thank everybody for listening to me on a lecture that is very important to me in my practice. If anybody has any questions, please feel free to give us a contact through the Iowa Specialty Hospital and Clinics Marketing Department. We're always happy to reach out to you and answer those questions. We want to take this opportunity to thank everybody for allowing us to take part in the care of your student athletes.